At this point, I'd like to introduce our first speaker, Patsy Brannon. Dr. Brannon is a registered dietitian with a research focus on nutritional and metabolic regulation of gene expression, and will set the stage for the morning. And there's much more we could say about Patsy and the other speakers. Do look at their bios. Patsy, welcome.
Thank you, and I appreciate the opportunity to set the stage, and I have no substantive disclosures, but the ones that I will make are here. What I want to try to do with you in the next 20 minutes is a little bit of an overview of where we've been, and that's population-based dietary guidance, with a little bit of a reference to food-based dietary guidelines and dietary requirements, and I want to then talk a little bit about nutritional kinetics and dynamics relative to population-based dietary requirements, and transition then to nutrigenomics and individually based dietary guidance and personalized nutrition, as it's often referred to. And I want to conclude with a little bit about the complexities for what I see as a transition ahead, and then introduce the workshop as it's going to unfold over the course of the day. So with that in mind, I want to come back to the first two steps of the risk assessment framework, which underlies many, not necessarily all, of the dietary guidance approaches for population-based recommendations. And the first of these is to identify the hazard control, that's risk assessment speak. In our context, that's really a health outcome, and it's based on a synthesis and review of the evidence. And the second step is to characterize the dose-response relationship of the exposure, in our case nutrients or diets, with the health outcome. And those two steps are central to why we use a population-based approach, and I want to focus on that for some time. So in thinking about synthesizing the evidence, I drew on food-based dietary guidance from the European Food Safety Authority, EFSA, and also to some extent from the U.S. Dietary Guidelines, particularly focusing on the Nutrition Evidence Analysis Library, and the also then on nutrient requirements in terms of the dietary reference intakes, the DRIs, particularly as the model has been, and I'm going to make a little bit of a comment about what's proposed for the DRIs for chronic disease endpoints as well. So EFSA, in its scientific opinion on establishing food-based dietary guidelines, focused on dietary patterns, which is comparable to the focus in the U.S. dietary guidelines, and emphasized desirable food and nutrient intakes. But the focus was really also on diet and disease relationships of relevance to a specific population. And the population-based approach is explicit in their opinion on how to establish dietary guidance. And they use a stepwise approach of identifying the health relationships, which is, we've talked about that first step. And for Europe, they also emphasize country-specific diet-related health problems. In the U.S., we look at U.S. health problems and the public health significance. Identifying nutrients of public health concern, which is comparable, thinking about foods relevant for food-based dietary guidelines, and food consumption patterns. And many of these steps are comparable to steps that are also taken in the U.S. dietary guidelines. And I thought I would focus just a minute on the one of the analytic frameworks that was used for the U.S. dietary guidelines in synthesizing evidence, in which, again, it's population-based. It focuses on exposure with dietary patterns and outcomes. And in this case, it's related to cancer, and it looks at several outcomes for cancer in terms of incidence of breast cancer, of colorectal cancer, of prostate cancer, and of lung cancer. So there's selected outcomes on which it focuses. Now, the DRIs begin to help us think about why a population-based and why the approach and why it's different from what is possible with nutrigenomics. And that is because there is a distribution of requirement Can I go back? I'm not sure I can go back. Yes, thank you. There is a distribution of requirement in terms of the selected health outcome or adverse health outcome and the intake. And this distribution then is related to how we set population-based dietary reference intakes. I have shown here the names for these dietary reference values. The European approach has comparable values, an estimated average requirement for 50% of the population, a recommended dietary allowance for 97.5%, and then an upper level where adverse effects begin to be seen. And the proposed chronic disease, DRI, proposes a range of intake. And I've shown two of the possible distributions. Their report, which was published this year, gives several possible distributions. This is a distribution in which increasing intake decreases risk and an increasing intake increases risk. And what they recommend is a range of intakes that are associated with decreased risk and a range of intakes that are associated with increased risk. And then also shown in green is an acceptable range. Now, the issue of why population-based, I think, is worth saying explicitly, and that is because for any given individual, shown here, a specific individual in blue out of a population, we have in the past been unable to ascertain where that person falls in this population distribution, and therefore we have been unable to give a specific recommendation for an individual. And that's at the heart of the change of what nutrigenomics opens up as a possibility. And that is going to be true whether you are looking at the current model or expanding to the proposed model with chronic disease endpoints. And this distribution of requirements should have us asking the question, why is there variability in requirement for a nutrient or in the response to a nutrient or diet component related to health promotion or disease prevention? And that brings me to talking about the nutritional kinetics, dynamics, and requirements. And I wanted to frame it this way because I think it's useful to step back and say, why do people actually vary and why is there individual variability? And I'm not trying to capture all the factors, but I'm trying to capture what I see as some of the most relevant factors. So when we think about what people consume, there's a kinetic aspect to the nutrient concentration at the site of action, and there's a dynamic aspect to the nutrient action at that site. And in terms of the kinetics, we can be thinking about processes that relate to absorption, which can include digestion and bioavailability, to the distribution throughout the tissues, which can relate to volume of circulating fluids and volume of the compartments into which they're being distributed, and body composition. We're also thinking about metabolism and metabolic rates and excretion and the rates of excretion. When we think about dynamics, we now have to turn our attention to the dose response actually at the site of action, and this brings up complexities in terms of differential distribution of nutrients in different compartment pools and differential effects. We also are interested in maximum efficacy and the temporal response as nutrients are consumed. When we begin to think about adverse and or beneficial effects, we're thinking again about dose response at the site of action and the target tissue, deficiency or toxicity, but now with the new proposed model for DRIs for chronic diseases, we also need to begin to think about ranges of dose response effects and the temporal response. And as we learn more and more about the inflammatory response, it's very clear that the dynamics of nutrients, as well as some of their kinetics, can be influenced by the inflammatory response. So when we think about why this inter-individual variability, a number of factors come up, and the first three are all relevant to nutrigenomics: genetics, epigenetics, nutrient-gene interactions. And as we're here today, genetics is not, as most of us frame it, in terms of just nuclear genome. It is also about the mitochondrial genome and their interaction. Age, sex, physiological state. This can include growing, pregnancy, lactation, stress, which you'll hear about later today in terms of conditional essentiality, disease, but also nutrient diet interactions, nutrient environmental interactions, and drug nutrient interactions. So there are a variety of effects. But in this model, it becomes quite clear why nutrigenomics can help us understand what an individual needs as opposed to an average for the population. So I did do my due diligence, and I Googled nutrigenomics because I thought I knew what it meant, and it turned out that what I thought it meant largely agreed with what others thought it meant and how it was defined, including such authoritative bodies as Nature and medical dictionaries. What I found interesting was that although all the definitions included nutrients and their impact on health and the interaction between nutrients and genetics, they varied in how they posed those relationships. So some posed it as nutrients affect health, and it's mediated through genetics. But in point of fact, the more reflective definitions pointed out that nutrients and the genome interact with each other, and they're mutually influencing, and that nutrients influence health and the genome influences health, and that their interaction also influences. What was also interesting was the variability in whether it was nutrients or diet or foods or food components. And in fact, this raises some of the complexities of how nutrigenomics is framed and what its impact is going to be for thinking about giving nutritional and dietary guidance to a specific individual. What also was not so clear and should be clear, and we need to keep in mind, is that it isn't just that nutrients, diet, food, and food components influence health interacting with genomics. It's also that health influences nutrition, and that can also influence the genome. And the mutuality of these interactions is something that I think also is important for understanding the complexity of the relationships that we'll be talking about today. And it is our ability now to identify and understand, or at least sequence, the genome of a specific individual that raises the possibility of personalized nutrition. So as we understand this interrelationship of nutrigenomics and health, it is our possibility to then understand at an individual level where that specific person is that allows us to tailor their nutrient and diet recommendations. But the complexities of these relationships are readily evident in this figure, which I've taken from one of our speakers' recent publications, Dr. Ordovas, thank you very much. And as we've already discussed, diet is more than, nutrients are more than just single nutrients. We have the food and the variety of food components, the food groups, the dietary patterns, and the interventions with diet or foods that we have to think about. And what is exemplified in this diagram are the complexities of these interrelationships with the genome, whether you look at it in terms of single nucleotide polymorphisms, or you are considering the issues of genetic risk score, or you are looking at next generation sequencing. And these interrelationships are multiple and complex, and they affect different phenotypes for cardiovascular disease, and they interact in their effect in different phenotypes of these complex diseases. And so as I was looking at various thought pieces about nutrigenomics and personalized nutrition, this one stood out to me as a clear visual example of just how complex these interrelationships are and the complexities that will have to be addressed as we begin to apply nutrigenomics to specific personalized nutrition. If we're looking at a single SNP for a single disease with a single nutrient, the pathway becomes less complex. But when we are talking about making recommendations for the entire diet for an individual that includes and addresses these single nutrients, multiple nutrients, interactions of nutrients, interactions with nuclear and mitochondrial genome, and other lifestyle factors that influence health and disease risk, it's a challenge ahead of us, but an interesting challenge. And so I want to add to this complexity by talking a little bit about the consumer. Granted, this is a molecular nutritionist, albeit in a registered dietitian's perspective on the consumer, but I want to state quite simply that consumers and food behaviors are very, very difficult to fully elucidate and understand. And each consumer is him or herself a complex psychological unit. And that complex psychological unit informs both poor behavior choices, food behavior choices, and good behavior food choices. And so these are issues that we're going to have to think about. And I didn't try to be exhaustive about this. This is now some of my thinking and opinion. I think when you look at the body of literature on consumers and food behaviors, it's fair to say that health is not the only driving force, and likely not even necessarily the major driving force. The theory of self-determination would suggest that it can be an important driving force, and we know that as individuals' health changes, their influence and willingness to think about their health and framing their food choices can change. But I'm here to tell you that I know many clinical dietitians that wish it were so simple as to tell a patient, you have this disease and you need to make this change in your diet, and they get 100% compliance. The reality is far different and more difficult to understand and influence. One of the interesting things about consumers, and this won't surprise anybody in this room because each of you eats, is that taste is often the primary force. Think about how often we've been with fellow nutritionists, and at lunch they say, well, I know I shouldn't eat this, but I really like the way it tastes. And it's almost said with this sort of guilty chuckle, but it is the reality of how people choose their foods. And nutrigenomics is not going to change that reality. It may change how they frame their choices, it may influence how they prioritize health, but taste is still going to be an important factor. Behavior change is neither easy, nor, as I've alluded to, do we fully understand it, nor are we necessarily as effective in facilitating it in our clients and customers as we would like to be. And finally, think about the individual consumer who is barraged by conflicting information about the risks of for disease, conflicting information about diet, conflicting information about what to do about both of those things, and now conflicting information about nutrigenomics. And I think it is that context that we need to keep in mind, that the consumer is going to want simplicity, clarity, and direction. And as we move forward in nutrigenomics and the future of nutrition and diet advice, we're going to need to keep in mind what consumers are going to want. And I want to think about a different aspect. Many of the things that I've heard discussed around nutrigenomics pose it as either population-based guidelines or individual personalized nutrition. And I don't think the world is going to be that simple or that clear-cut. And I think we are going to have to integrate population-based dietary guidance with personalized dietary guidance. And I think that because there are 43 nutrients that have to be supplied in the diet. They're in variable amounts in different foods. For example, there's more protein provided in MyPlate, for those of you familiar with the US MyPlate dietary pattern, than is actually required in the DRI. Why is that? It's because some food groups rich in protein are rich in micronutrients that aren't so abundant in the food supply, like riboflavin. And so when you model to achieve a dietary pattern that will meet the needs for all 43 nutrients, you are modeling a very complex set of multifactorial interactive issues, and you have to think about that. There are also the issue of other bioactive food components, and our knowledge of nutrigenomics, with all due respect, I don't think we're going to leave this room thinking it's complete. We have much more to learn and many more complexities to understand. And so what we're going to do today is begin in session 1 with a look at the interrelationship of diet, genomics, and health or disease prevention, whichever lens you prefer. How can we apply nutrigenomics to diets tailored to individuals in session 2? What are some of the policy and ethical implications in session 3, with a close look at the nature and strength of the evidence, both in terms of what it needs to be and what it is, in terms of consumer perspectives and behaviors and ethics, and finally concluding with the panel discussion on the opportunities of nutrigenomics and the future of nutrition in session 4. Thank you very much.